I'm going to turn it over to panel and let them get started, but I've had opportunity to meet everybody. Bob, today's the first time we've met, but I've been very fascinated by the work that this group has been doing on thinking about the issues of healthcare coverage for those that have not had access to healthcare coverage. And we know what a tremendous problem that is, what a differentiator it is from pregnancy through early childhood through old age. And you know, we all struggle with our own issues around the expenses for healthcare, but so many people do not have access to it at all. And this wonderful group has worked for the last couple of years on this initiative to figure out how to bring healthcare services to everybody in the county. And during that process, the Healthcare Reform Act, I guess Mr. Obama has said now it can't be called Obamacare, so I'll use that term. I always thought it was a little derogatory, but he's embraced it. So with Obamacare, I think it's created lots of uncertainty. I think many of you probably are for it, many of you are against it, but it's coming. Even if the election goes against President Obama, I think there's still going to be this legislation to deal with. And I consult to doctors, I consult to Blue Cross, and virtually in hospitals, virtually everybody is going like mad to try to figure out what it means, but it's very, very hard to get a grasp on it. So hopefully we can address, I think we'll start out with addressing the Washtenaw piece and then open it up to more of the national implications. So Bob, introduce Bob, and then Bob, everybody will introduce themselves. So Bob, I'll let you start with introducing yourself and go from there.
Thanks, Rob. We're really, all right. Is this all right?
Yeah.
We're really pleased to be here this morning, and it's a great cross-section of folks, I think, that have interest in many different ways in the work that we're doing. The Washtenaw Health Initiative, how would you define it? I would define it as a loose, unincorporated association of community members who are trying to do a better job of delivering care and providing access for a population we're focused on, and that's low-income individuals, Medicaid recipients, and uninsured. So, you know, I spent several years as county administrator, and in that position, the county partnered with the two hospital systems, St. Joe's and UNM, to put together the Washtenaw Health Plan to help serve that population. And we were able to leverage about $500,000 of local dollars to bring in millions of dollars within partnerships with the hospitals to provide service for about 8,000 individuals. So there are 8,000 individuals in our community who wouldn't otherwise have insurance who are insured through the Washtenaw Health Plan. And under the Affordable Care Act, that'll actually be phased out because of the wide expansion of Medicaid. But during that time as county administrator, made a couple attempts to even broaden our effort to see whether locally, because they couldn't do it at the federal level or the state level, to see whether there was ways we could get increased access, if not universal access, to health care in Washtenaw County. You know, the idea here is a business case, but a humane case. We know that folks without health care are treated somewhere, usually in the ED, usually later rather than earlier, and many of us think that is to the advantage of the community to have that coverage for everyone in the community, to talk about primary care and the like. And the hospitals agree with us because they spend millions upon millions of dollars in charity care. Well, I think you all know that. Our efforts weren't necessarily successful over and above the Washtenaw Health Plan. But a couple of things happened in the last couple of years to bring this organization together, and that is the Affordable Care Act passed, and ready to plan. And my partner here in crime, Bob Laverty, thought he could maybe bring the community and the providers and the stakeholders together to see whether we could do a better job of providing access to health care for that population, but also coordinate that care in a better way. And he's going to describe what he did. But in terms of the Affordable Care Act, we know that about 13,000 more of our citizens will be eligible for Medicaid if the state approves the expansion of Medicaid. And another about 11,000 of our citizens will be able to get subsidies through the Affordable Care Act. So this was an impetus for Bob to proceed. So our presentation, as Rob said, is about how we formed this initiative, what it means for the community, and it's very important for you as community leaders to hear that so you know what we're doing and we get your ideas. We also know, as Rob said, that there's some interest about very specifically what the Affordable Care Act might mean to your businesses or your ventures, and Marianne is really the expert on that, so we want to leave plenty of time at the end to get those questions. Let me just make 3 key points and ask you to listen for these. Number one, we are not partisan. We are not commenting on the wisdom of the Affordable Care Act, healthcare reform. What we're trying to do is to get the community ready to for that big change that's going to happen, and to have community groups, a community group that can come together. Second point I want to make is we're almost all voluntary. This is our one staff. And we have great support from Marianne and Herbert. I'll tell you about that. But this has been very voluntary. Third point, keep in mind, this may offer an opportunity for community planning sustainably going forward, no matter what happens to the Affordable Care Act. Can we as a community come together when there's so many different players? It's really a hodgepodge, but we have been successful so far with the cooperation of the hospital. So this has some real possibilities going forward. And again, my friend Bob Laverty, who's dealt with these, sees some real possibilities. So let me turn it over to Bob. We have about probably half an hour, 35 minutes, and we need a lot of discussion and questions.
Thanks, Bob. First of all, a little bit of my background. I'm a retired healthcare executive. I was the CEO of St. Joe's for about 18 years. I was there when we moved the hospital from downtown Ann Arbor out to Superior Township across from the community college. And I still call it the new hospital, although what I built they tore down. It's amazing, I was mentioning to some others, that building was in place for 30 years. And it shows you the problem of obsolescence. It just wasn't capable of meeting the new technology challenges. So a beautiful new facility. I was at St. Joe's as the CEO for about 18 years, and then I managed, kind of coordinated all of the Mercy hospitals across the state of Michigan. We were in 10 different communities, and learned a lot about this state and the diversity in the state, and unique health problems in various communities, and also common health problems. And then I retired in 1999. My goal was to retire by the time I was 55. I beat my goal by 1 year. So Rob, this is all part of the coaching to have set goals and try to exceed your goals. So I retired, and then took a break from healthcare, and then subsequently became a board member of Packard Health, which is a safety net clinic, and also joined the Washtenaw Health Plan Board, which Bob described. And what happened was in 2010, that's when the national discussion began again about major healthcare reform, which led to the Affordable Care Act. And being on a safety net clinic board and Washtenaw Health Plan board and my background in healthcare, what really struck me early on is depending upon how that plan is ultimately implemented, and we really don't know, right? I mean, we have an election, how it's going to spin out is unclear. But the only thing I can predict is there will be major change in delivery of healthcare, no matter who gets elected, what the Congress is. We have some major problems in this country, and they're going to get addressed politically. So the problem, you know, the passage of the Affordable Care Act gave us an opportunity to ask the question, are we ready in this community to implement changes to accommodate that act? And the experience I had on these boards was that everybody was wringing their hands about how is this going to impact me, my organization, am I going to go out of business? Bob mentioned if it goes through, Washtenaw Health Plan may no longer exist or its role will change. What about the safety net clinics? We know from Massachusetts when a comprehensive health reform was passed, they were overwhelmed with demand. How would we accommodate that? Is everybody just going to go to the ER? What is the impact on the two healthcare systems if that happens? So a lot of hand-wringing. And what occurred to me is we didn't have the capacity to come up with a plan for our county. We have a very good public health department, but they just aren't geared up to do that kind of planning. In my own experience in healthcare, we have been through a couple of iterations historically on doing a comprehensive health plan. And my biased opinion is it was a failure. And the reason it was a failure in the past is that it became a regulatory mechanism. So the planning agencies became organizations that you had to apply for permission to do something, buy a new piece of equipment, or expand a program, or add beds. And so, you know how we react in business. If we have a regulatory system, our objective is to beat that system. Do whatever is necessary to further our business purposes. And so those efforts fail. And the result is, in our community and many communities, there is not a mechanism to do planning to get ready for this kind of a monumental change. So what happened was, I started a series of discussions. I talked about 26 different people, safety net clinics, insurance companies, government in our community, Bob, and others, to see if there was a willingness to begin to do some comprehensive planning to get ready for the Affordable Care Act. And I would say unanimously people said, yes, we ought to be doing that. So the part of the discussion was, what are the barriers to having a successful discussion or developing a plan? And the number one, hang with me here for a minute from the health systems, the number one barrier, people said, were the two health systems. And which is odd. And the reason is because historically we'd had a lot of intense competition. And the smaller organizations said, you know, we've tried this in the past. We've tried doing some community-based planning. And what happens is the two health systems come out of the woodwork and start to compete. And we kind of are in the peanut gallery up in the bleachers watching the competition, and nothing happens. It sort of dissolves into a competitive situation. So that's one of the significant barriers. And they said if this is going to work, we have to have the total buy-in of the two major health systems, and they have to put down the competitive swords and work cooperatively. So to get it started, I had meetings with the two CEOs, Doug Strong and Rob Casselou. and discussed with them their interest in doing this community-wide planning. They had a high level of interest. And I said, you know what the problem is? They said, no. I said, you're the problem. That's why people would be reluctant to participate and kind of bare their souls and come to the table with an open agenda and discuss this. And fortunately, and coincidentally, they said, you know, we've been looking for new ways to cooperate together, and this would be a wonderful opportunity. And so what I asked them is to personally participate. Don't delegate this to, you know, your head of planning. Because you know what happens in big organizations? When you delegate it, the person down the line says, I don't really know what the agenda is for our organization, so I better play the cards close to the vest. And I don't want to do anything that disadvantages my organization. Well, the only person that can overcome that is the CEO. They set the agenda for the organization. So they had to agree to personally participate, which they have done. They've been to virtually all the meetings. They have supported this effort financially. The other thing I asked them is, I said at the initial meeting of the big group, which we call the planning committee, I would like you to get up in front of the group and give each other a hug. And they did just what you did. They sort of laughed. So at the meeting of the first meeting of the group, I asked them to get up and give each other a hug, which they did. And I wish we had that for you. But it was a signal they were willing to work together. Some other preconditions that the participants had was that we had a very clear definition of the problem we were trying to solve. They didn't want to participate in an effort where we spent months and months and months developing a big plan that you put in a book and you put the book on the shelf and nothing gets implemented. They wanted to make sure that we had some well-defined problems, and we said, you know, 5 to 10 specific action steps that we could implement that would make a real difference. So that was a precondition. Third, they wanted to make sure there was an accountability back to the community. This couldn't just be the providers getting together, coming up with a plan that was in their best interest. We had to keep the community's interest at the forefront. Well, how do you do that? And what we came up with was to invite two of, I think, the most credible community leaders we have to be co-chairs, and that's Bob and Norma. By the way, we are the 3 retirees with 1 working woman behind this effort. And the way we accomplished that, Bob and I were neighbors. I'd see him out when I was walking, and I'd tell him about this, and I said, would you like to, he was getting ready to retire, I said, would you like to be a part of, well, geez, I want to travel. And I kept working on him, and I said, you know, you and Norman have done some great things in the community, and Norman has agreed to do this, so you'll do it. I said, oh, well, I guess I sort of have to. And then I went to Norman and I said, you know, Bob has agreed to do this, and you'll do it. And so Norman agreed. And so there are 2 co-chairs, and they keep us honest in terms of making sure that our efforts really do reflect the interests of the community. And then the final thing was, this is a huge effort. It's all volunteers. How you herd all these cats and move in a clear direction. I was talking with Marianne, and she'll tell you about her background. I've known her for years. And she was very excited about the effort, and I said, we need a facilitator and support to move this effort forward. And she said, you know, I might be interested in doing that. And that was very key, both Marianne and her knowledge and background, and her staff, and the chart organization, and making sure that we set an agenda, we had an effective process, and developed some real outcomes. Last thing I would like to say before I turn this over to other members of the panel is, why is this important to you as business people? Because, as Bob said, we think we have hopefully established a successful model for continuing the planning process for healthcare in our community. We all have a stake in that. Personally, your businesses have a stake in it. We have some new people here out of healthcare that I haven't met before. We'd like to get you involved in this. This is an open process. And we need more involvement of the business community. After all, you have an agenda, you have knowledge, you have a stake in the success of this community, and we want to involve as many people as possible. We now have 70 people involved actively in this program, and it is an open door. So I would really invite you to, if you have an interest in these issues, to consider participation with us. We need your advice. We're open to ideas. And so we're really happy to be with you today to share what we've accomplished to date. Marianne.
Morning. It's wonderful to be here. It's great to see all of you and have a little bit of a chance to talk with you both about the Washtenaw Health Initiative and more broadly questions you might have about healthcare reform, the Affordable Care Act, the impact on small businesses, etc. But I'm going to talk right now a little bit about the Washtenaw Health Initiative and pick up where Bob left off. And the one thing he didn't tell you when he said that he asked me to help facilitate it is that he said this will only last for 6 months. And then we'll be done. So almost 2 years now into it, we have no end in sight, which is actually very exciting, but it became a much bigger commitment, which is why we were very fortunate to have some financial support from the hospitals in the community, the United Way, and our very Community Foundation to help us hire Barry to keep the effort really moving forward. Bob told you, and both Bobs actually told you, what a broad-based effort this is. We have 40 different organizations, more than 70 people, some of them are here, and we're delighted that you're here, involved in trying to make this place, this community, more accessible, provide better health care with a particular focus on the low income, the uninsured, and Medicaid recipients. And in order to do that, as we brought all these diverse organizations together, we said, before, people who work in the field always have ideas about what they want to do. And generally with groups, when you start talking about the problems that we're talking about here, they say, well, here's the solution. So what we did in the Washtenaw Health Initiative was to start with a process that said, for the first 3 months of our work, we're not going to talk about solutions at all. We're going to really focus on what the current state is and what our goals are for our community. And so we began our process by looking at healthcare broadly in our community. Where do we have the gaps and where do we have opportunities and what are our goals to make it better? So just a little bit of background about me and how, what I brought to the process. I run an organization called the Center for Healthcare Research and Transformation, which is a nonprofit partnership between the University of Michigan and Blue Cross and Blue Shield of Michigan. And our goal is to improve the use of evidence-based medicine, improve population health, and improve access to health care. And so this initiative very much fit with our mission, with our goals. And our goal is to do this statewide and to really help change healthcare nationally. And so we actually see the Washtenaw Health Initiative as a demonstration project that we hope other counties, other communities across our state and across the country engage in.
What were those 3 things? Evidence-based?
Improve evidence-based, use of evidence-based healthcare, improve population health, and increase access to healthcare. And we do it through a variety of ways, and I can talk about us later if you're interested in some of the other things that we're doing, but this initiative is very much part of those goals. And we see it as having a very big impact in really all 3 areas. My background, before I became the director of the center, I ran the Department of Human Services for the state of Michigan. I was there for about 4 years, appointed by Governor Granholm. The Department of Human Services deals with the most vulnerable of our citizens. It includes the programs that provide public assistance for individuals throughout the state, as well as the child abuse and neglect system, juvenile justice, child support, just the broad range of human service activities in the state. So I also brought all of that background to this initiative to help as well. And then before that, I'd spent about 20 years at Blue Cross and Blue Shield of Michigan with a brief tour into the mercy system where I got to know God. And also in healthcare for a very long time. So in our initiative, as we began our work and looking at where the gaps were, we focused in several areas. We focused in one major category of things we looked at were getting people enrolled in Medicaid. About 14% of those who are uninsured in our state today are already eligible for Medicaid, independent of what happens with the Affordable Care Act and the Medicaid expansion. But many of those people who are eligible for Medicaid but not enrolled don't enroll because they face barriers. It's an extremely complicated system, and in fact, as part of this initiative, we mapped all the different ways you can get into Medicaid. There are 40 different ways to get into the Medicaid system. 40 different ways. They all have different criteria. People come in, they come out. It's a very complicated process today. It will be much simplified if the Affordable Care Act goes into effect. But today it's very complicated, so people face barriers. And we wanted to figure out how we could reduce barriers so that people who were eligible would get that coverage. The second area that we focused on had to do with access to care, integration of care, and coordination of care. And there we looked particularly at primary care, mental health, substance use, and dental services. And in all of these areas, we have significant gaps. The Bobs told you that when Massachusetts implemented healthcare reform, they had a huge demand for primary care, and they were not able initially to meet all of that demand. And so we wanted to do planning in our community to say, okay, we know how many people are going to be eligible for Medicaid. We know how many people will get coverage through the health insurance exchanges that small businesses in particular might have. And how many more primary care physicians do we think we might need in the community? We actually have just finished all that mapping, and we think we'll need 5 to 7 more primary care practitioners who are willing to take Medicaid patients. It's not really that we have a shortage of primary care per se. We have a shortage of primary care physicians, dentists, and others who will treat Medicaid patients. And that's because Medicaid is an extremely low payer. Medicaid pays for primary care today 44% of what in Michigan, 44% of what Medicare pays. Now that will change actually starting in 2013 because of the Affordable Care Act, but today it's very difficult to find practitioners if you're a Medicaid recipient who will treat you. And so that's really what we wanted to focus on there. Similarly, we have significant gaps in the community on mental health, on substance use services, and as I said, dental care is probably even more difficult for people to find practitioners than primary care. So we did all of that mapping. I think we gave you in your materials a picture of healthcare in Washtenaw County. And then in the second 3 months of our 6 months work, we looked at some of the solutions, and the groups came forward with 11 different recommendations. They all address all of those areas. They're also included in your packet. But I'll give you just one example, and then I'm going to turn it over to Norman. We're going to talk a little bit about how we've structured our effort. The example I want to give you is on the eligibility and enrollment. There, one of the members of the Washtenaw Health Initiative was the county Department of Human Services, and they partnered with the CEO of the Washtenaw Health Plan to look at the data we had. We even mapped by subdivision in the county where we have access needs, where we have people who are uninsured but eligible for Medicaid. And they said, we think what we need to do is move some staff from the county office of the Department of Human Services into the community to help people get enrolled. And so they moved 2 staff that the state committed to provide 2 of their existing staff of the Department of Human Services office in Ypsilanti, move them to the Washtenaw Health Plan, and they go out now in the community to the safety net providers to help get people go home. They have, in just this very short, several-month period, had more than 1,000 people in our community that they have helped to keep Medicaid, and get other assistance programs they're eligible for, like food assistance. It's been an amazing effort, and it just shows you that it didn't cost anything to the state. They didn't add staff. They just redeployed their staff in a different way. And I think it's an example of how when you come together as a community with diverse people, where you really understand what the needs are, you can see the kind of creativity that comes forward and that can help us really achieve those goals. So it's an example. We're moving along with all of these different initiatives. It's a very exciting process. We have tremendous group of volunteers, and Gloria, you can talk a little bit about the work from your own perspective, but it's just really terrific to see this group come together to do that voluntary community-wide planning that Barbara done. So I'm going to turn it over to Norman.
Good morning.
Good morning.
I come to the initiative with no particular experience in healthcare. I retired from the university now some 10.5 years ago. I was responsible for the university's investment portfolio, which included the endowment portfolio. Made a number of significant changes to that portfolio during my tenure. Today it ranks as one of the strongest endowment funds in performance, as well as largest in the country. My engagement, if you will, in the community in the more recent period of time has been through the Ann Arbor Area Community Foundation, and the opportunities to work collaboratively, if you will, is something that we've always wanted to advance. There are opportunities for more efficiencies, and so speaking some now years ago with Bob Laverty, because of the work he was doing with Packard Health, safety net provider, we began to talk about other opportunities here within the community, and he extended, as he indicated, the invitation for me to get involved. And I've very much enjoyed and learned a lot by the process. What is significant, as one of the Bobs have said, is the opportunity to work in a voluntary effort with the 2 major hospital systems here in the community in a collaborative way. And a number of things have happened since that time that you've seen announced here in the community about the work of both St. Joseph Mercy Hospital and University of Michigan Hospital systems as well, health system. We started out saying that the steering committee was about 12 of us, and as indicated, both CEOs for the 2 hospitals were required to participate in our monthly meetings. We then also invited initially about 35 people to serve on different committees, work that Marianne's described, and those volunteers came from a number of the agencies here within the community, some of which you represent as well. That group of 35 we refer to as a planning group, and you've got in your material today the names of a number of those people, but more importantly, that group has now expanded to about 70 different people that make up, if you will, what we refer to as a planning group that gets together on a quarterly basis and shares the information of the work within each of the work groups. And the reason we want to share it is that we will, by exchanging information, benefit to know both what's being done in the other committees, other work groups, and questions can be posed that we then can take back, or information exchange that can be taken back to the respective work groups in their further deliberations. As Bob indicated, or Marianne indicated, we thought we were going to start with 5 or 6. We started with about 11, 9 of which went into some stage of implementation. 2 were under further study. They've now been, I think, merged more into 9 active groups that continue to work on implementation, if you will, pilot projects, so that we get the experience in advance of 2014 of how some of these things can be effective. Our objective, as described earlier, is to reduce the use of access to health care through the emergency rooms, but encourage use through primary care physicians. And there is an initiative that goes on, as an example, with some of those more than 1,000 people that are now signed up, eligible for Medicaid. They're also being assigned a primary care physician. And working with Blue Cross Blue Shield on one of our pilot projects, we assign those individuals to primary care physicians and are measuring and evaluating how they are then being seen. The expectation is within the first 90 days, they will be seen by a primary care physician once enrolled. And we are hoping that that individual then will continue on a regular basis to see their primary care physician, and you begin to see and appreciate the type of change that we're trying, if you will, from a behavioral perspective, to affect. As an organization, as has been indicated, we're primarily voluntary. The first 6 months to a year was entirely voluntary, including the very effective work that CHART has provided under Marianne's leadership. Recognizing that we were beyond our 6-month sort of engagement that Bob Laverty invited us for, we had to then begin to think about issues of sustainability. First is, would we in some way try to become a nonprofit organization, entity, fiduciary organization, whatever? We as a group, steering committee, discussions with planning group, elected not to incorporate in any way, but to remain voluntary because it was our belief that that was the real glue, if you will, in the work that was being done so effectively. We did agree that we would come back and revisit that on almost an annual basis to be sure that it's still appropriate, and or what adjustments do we need to make in order to make certain that the sustainability is carried on. We continue going into 2013 thinking that we're going to continue for at least the next year, continue through this voluntary initiative. But coming into 2012, recognizing all of the work that CHART was doing, we needed to begin to think about how do we fund some of this initiative. Pilot projects in and of themselves will take on some financial responsibility. The 4 of us have agreed to serve as sort of the leadership of the steering committee, in particular as it comes to financial matters, and we will listen to business cases that are developed by each of the work groups for their particular project. They will come to us with that business plan and identify resources anticipated in terms of need. We then will attempt to identify a source. We've had conversations, Community Foundation of Southeast Michigan, with Michigan Council Foundations, with United Way, with the Ann Arbor Area Community Foundation, with the Washtenaw County Commissioners, with the City Council for Ann Arbor, City Council for Ypsilanti. Again, the idea is make certain that everybody is informed and that all understand what we're attempting to do at the outset, at least in terms of voluntary, but also recognize that the commitment of in-kind service on the part of each of their staff from the respective organizations represents a significant contribution. We measured last year, asked for feedback in terms of time spent, and we determined that there's 8,200 hours of commitment that have been provided through the last calendar year. When we faced 2012, we went to the 2 fund sponsors, the 2 hospitals, as well as the county commissioners, the city council, United Way, the Ann Arbor Area Community Foundation, and said, we all need to participate in the funding for the work that CHART's doing, and it's not covering it by any means in its entirety, but at least a token, at this point, contribution. And all those organizations provided funding support. It's critical that the hospitals not be viewed as a deep pocket. but that it become a community engagement, and that's the reason that we need to go beyond just, if you will, the two hospitals. And as indicated earlier, the reason we also need to begin to talk to businesses and others in the community, because when we think about funding some of these pilot projects, as well as the additional work that will be required, we're going to need to do this as a community. In your packet, you will see there's a charter. And while we're voluntary, we ask that each of the existing 34 members of this that have signed the charter subscribe to the work that's being done. Specifically, we spell out the mission of the Washtenaw Health Initiative, which is to help improve the health of low-income, uninsured, and Medicaid recipients in Washtenaw County by bringing these organizations together to coordinate and leverage resources, to share information on gaps in care, opportunities to fill those gaps in organizational plans, consider opportunities to work together on specific projects and/or functions, and to generate innovative ideas, plans, and implementation approaches to improve care and access in the county. We go on to state that the leadership of these organizations support WHI, so we want to be certain that it's not just the staff members that are part of our working group that are informed about the work we're doing. We want the leadership of those organizations, and that's the reason all those governing boards for those 34 organizations have been informed and are aware of the work that's being done. Again, our way of trying to advance, if you will, an understanding for what's being done. So when the organizations adopted the charter, they then signed it and returned it, and Bob and I have countersigned on behalf of WHI those charters. We will re-up all those organizations now for 2013. Again, at least an annual communication is critical so that they understand the progress. We will issue a report that talks about what's been accomplished in 2012 or to date. So again, lots of important work being done. It's important we, if you will, share, and now you are all invited as ambassadors of the WHI to share that information with your colleagues and others here in the community, because the work is critically important. Thank you. Go ahead.
Yeah.
Go ahead. I was just going to say we're open for questions.
Okay. Well, and,
Go ahead.
yeah.
Well, I had more a comment. Here you are in Washtenaw County. You have two great hospital systems. You've got wonderful people, greatly experienced, committed, dedicated. Lots of money, lots of experience, lots of everything. This is very different from the Lac de Flambeau Indian Reservation, where I just built a dental clinic. What you are doing is a pilot that could be distilled and become a template for lesser communities. You know, there's really a larger responsibility. You see you all shaking your head. And so I commend what you're doing, but it's not just about taking care of these guys.
No, and we should say, one thing we didn't say is that we have talked with each of our, from Washtenaw County, our legislators, to inform them, take this information back to their colleagues in Lansing. We've also talked with Congressman Dingell because of all the work that he's done in introducing, if you will, the Affordable Care Act, and he too is interested in this model, which is, Marianne has indicated, that's part of what CHART is interested in doing, is sharing more information.
Marianne did not mention, I just came back from Washington. There was a big discussion about the disproportionate cost of end of life and how that is being driven by essentially the legal system that you have to do everything. You know this person's going to die, but you have to do everything to make sure that you can't be sued. And there was some discussion that that was 70% of the cost of the hospital. Maybe you know that better than I do.
Go ahead.
Talk a little bit about well, a couple of things. First of all, let me go back to your point about this, what we could do for others. Actually, we had a colleague of ours at the School of Public Health here at the university did an oral history on the Washtenaw Health Initiative and presented that with Carrie at the statewide Public Health Association meeting that had counties from the entire state there. And I think, Carrie, 30 counties in our state indicated that they would like help setting something up in their communities, and they are the kind of communities you're talking about, much more rural in many cases, or urban with significant problems. We are now in the process at our center working with the Greater Detroit Area Health Council to write a grant, we hope, for the Southeast Michigan Community Foundation to develop a toolkit, technical assistance approach to help other communities do this kind of work. We have lots of resources in our community, you're absolutely right. We have amazing leadership, we have very dedicated people. It is different in other communities, but we think a lot of what we've done here, a lot of our learnings can apply to others, and people are really eager to get that. So that is part of our goal. We've also talked with the state in the development, as the state was hoping to have a health insurance exchange, a statewide health insurance exchange. We can talk about that because that'll affect a lot of small businesses here. And we offered Washtenaw County as a site that the state could partner with to test the new health insurance exchange, to test the Medicaid expansion, et cetera. And there's politics at the state level, and they were not able to move forward, even though the governor wanted to, with a health insurance exchange statewide. But they're still very interested in partnering with us. And they also told us that they know of no other counties in the state that are doing the kind of community-wide planning we are. And so that was something that they very much also wanted us to encourage. So we are very committed to doing what you said. And just very briefly on the end of life, because I know Larry has a question, about 24% of Medicare expenditures occur in the last year of life. It's a very high dollar amount. We just actually did a study in our center about what you can do to improve the end-of-life experience. I'm sorry Gloria left before we had this conversation, because hospice care is a very important part of that. And some of the physicians here can tell you, I really don't think that the issue has to do primarily with legal issues, barriers to getting really quality end-of-life care, which for the most part is palliative care, hospice care, getting people treated holistically more earlier. I really think it is a much more complex, broader issue about medical education, physicians' knowledge of the alternatives, families' knowledge of the alternatives. And we will actually have, hopefully within the next few months, on one of the things we do at our center is try to help decision makers make better decisions based on facts. It's hard to believe that many legislators don't always use facts and they make that. So we're trying to help them do that, and we have we're going to actually provide a lot of information about end of life and some of the alternatives. And there's some things our state can do on a public policy standpoint to do that as well. The last thing I will say before on just generally, one of the studies we just published that is on our website has to do with the Affordable Care Act and the Medicaid expansion. We did an analysis of the impact on our state of the Medicaid, if the state, because of the Supreme Court decision, it's now an option for states as to whether or not they expand the Medicaid program. If our state does choose to expand Medicaid and get more of the uninsured covered, which would have a big impact on our community and communities across the state, over 10 years, the state would save $1 billion, and we would get statewide 619,000 more people with health insurance coverage in the state. So that's something we can talk also a little bit more about. It's a very big positive impact on the state. We're hoping the Affordable Care Act goes into effect because of the benefit it will provide to so many people.
Sorry. Following up on your comments about legislation.
Would you introduce yourself? I didn't came in with
Sorry, it's Roger Ferguson. Are you exploring promoting legislative changes that might expand or make this more successful, like independent nurse practitioners delivering of primary care?
Yeah. I think that personally, I think the biggest thing that would help us is the Medicaid expansion. We get so many people with coverage. The scope of practice for nurse practitioners is something that we've discussed a little bit. We're not, as Bob Guenzel said, we're not an advocacy organization, and so we're not doing advocacy for particular legislation. But I think it is important to note that in primary care, to the extent that we need more primary care practitioners to serve particularly the low-income population, that doesn't necessarily have to be physicians. And in fact, we have some data to show that advanced practice nurses do serve that population in somewhat higher percentages than physicians do, so it's an important opportunity. That legislation is, I think, going to be very hotly discussed in our state, as it has been for a long time.
It's probably worth noting, though, that within some of the planning, some of the work groups, we've identified the need for navigators both through the healthcare system as well as through access for enrollment. And so, you know, who knows how that is likely then to manifest itself if we can demonstrate the type of value that comes from that type of support. Clearly could be a benefit then to something going forward.
Just a follow-up. Comment more on where that $1 billion in savings comes from.
Sure.
Can you unpack that a little bit?
Yep. Yeah, it's very important to understand that. So most of the savings comes because the state today is paying for services for many people through state dollars. And if we do the Medicaid expansion, many of those people will become covered by Medicaid, and federal dollars will provide the vast majority of the cost. So in particular, the state today provides, pays for and provides services for mental health care for many people who are uninsured through the community mental health system. The state today provides some coverage for adults who do not have children. It's limited coverage through what's called the Adult Benefit Waiver Program. The state today provides health care for prisoners. And under the Medicaid expansion, almost all of those prisoners will become covered by Medicaid. They are not today. And so what will happen is that as these 600,000 or so people become covered by Medicaid, they will become, the state will no longer have to pay for those services fully themselves. Under the Medicaid expansion, for the first few years, the federal government pays 100% of the cost of those who get newly eligible, newly covered under Medicaid, and ultimately they pay 90% of the cost. So when we looked out and projected by 2023, it would cost the state only $83 per year for each individual covered in the Medicaid expansion. It's an incredibly good deal for the state. The other, just a couple of other pieces to that, the state, it gets built in and shifted to people who pay for insurance today. And so there are savings to the state with the Medicaid expansion as an employer, as there would be savings to all of you. We calculated about 0.5% to 1% of employers' premiums are going to cover people who are uninsured today. And so all employers will save money if the state moves the Medicaid expansion. And then the last area is a very complicated technical area, but today the state taxes providers, particularly hospitals and skilled nursing facilities, to bring more Medicaid dollars into the state. And because there'll be more Medicare revenue, those taxes will go up. So and you can look at it. Our website is chrt.org. You can take a look at all of the analysis there.
I had a couple observations, and I'm using a personal note because I'm dealing with a father-in-law. Yeah, I have a father-in-law right now going through this whole issue late in life, going through the whole thing. He just moved here from New York, where his physician was giving him quarterly chest x-rays under Medicare. Mother was getting monthly 12B1 shots and conversations with a doctor under Medicare. Came here, the doctor here was aghast. Went in recently for some problems. The other new doctor said, oh, we got to do an MRI on your brain, full scans. Went to the primary physician. We said, why are we doing this? What will be the outcome? Well, there isn't one. They're not going to do brain surgery. there wasn't any reason to do an MRI. So we're going through all these issues because they're free. I mean, as my father-in-law would put it, why not? They're all free, other than the fact that he's being radiated to death and so on and so forth. But I guess I come back, and I'm trying to understand, and this is more of a salient question, but when you look at Medicaid, and the issue is, you said it was, I think, 44% of Medicare, is that correct?
The payment for
Payment.
primary care.
For primary care.
44% of what Medicare pays.
What is going to happen to that to incentivize either physicians to take those patients, or that we're going to force them? We're going to find a few great volunteers, but how do we change that whole dynamic?
Yes, so under the Affordable Care Act starting in January, the payment for primary care goes up to 100% of Medicare to try to do exactly that, to incentivize more physicians to take Medicare patients. It's 100% federally funded, but it's only in effect for 2 years, 2013 and 2014. And the reason that they did that is because they're hoping that states then will follow through and also increase the payment after 2014 to primary care practitioners. And the idea was that by 2015, states will be in better financial shape and they'll be able to carry on this higher payment for primary care practitioners. Governor Snyder has said he very much wants to pay physicians. He recognizes that physicians are paid too little under Medicaid, and he wants to raise those payments. And so we're hoping that some of that $1 billion in savings that I told you the state would accrue from doing the Medicaid expansion could be redirected to making higher payments, to using them for higher payments to primary care practitioners.
So,
for 2 years.
What's your reaction? I'll follow up real quick. What is the reaction from physicians? Any indication, given a 2-year program,
Yeah.
why would I shift my practice and start taking these patients on a long-term basis with a 2-year window?
Right. So we don't know yet.
Oh, okay, that's
we'll
okay.
see. I mean, the physicians, I think, and Laverty might want to speak to this, in Washtenaw, and others might too. In Washtenaw County, we have a very integrated medical care system, a health system, and we have, St. Joe's has been buying physician practices. The university is very integrated. So here, the decisions are made a little bit differently than in communities where there are just a lot of smaller individual practices. Here, they're much more, so people in the health systems are very aware of this change and are doing all their projections and are sort of trying to figure out how to maximize that. And I don't know if you want to talk about that at all.
Well, I think a couple of the important things I've mentioned about this initiative, if I was sitting out there and I'd say, hey, I'm a small business person, why is this important to me? It looks like you're a bunch of do-gooders up there, just trying to help the poor and downtrodden. Well, number one, I would say we represent a spectrum, a political spectrum. I happen to be a conservative. I'm trying to break the mold that conservative people actually do care about.
You're a conservative in Burns Park, come on.
No, he moved.
The interesting thing about this initiative that may not be right on your point in responding that I just shared with you is we know there's a better way to deliver health care, not just to the poor, but to all people. Right. And with respect to the poor, those that are on Medicaid or other assistance programs, the real problem is they are not getting initial primary care, preventive services. They end up in the emergency room. You might say the emergency docs, well, boy, they'd be opposed to this because they're going to lose business. But the reality, if you talk to emergency physicians, they know this is not the best way to deliver care. It's episodic. We have a term in healthcare, people that keep returning to the ER called frequent flyers. And they come in with serious conditions. Maybe they're diabetic. They They don't have access to get insulin, they haven't been instructed properly, they have another crisis, they may get admitted, so the health systems really pay a price, which means we all pay that price. How can we change that vector? That's one of the key parts of this initiative. It's coordinating care, or we call them, care navigators. How can we, first of all, get people in earlier for primary care, assessment, preventive care, help people manage access across the various resources available in the system. And you know what's really interesting if you're a conservative? That hasn't done very well for me either, and I have insurance. Now I have Medicare.
And you're laughing.
You know, it's really interesting, even under Medicare, by the time I pay for Part B, I pay for Medigap, and I pay for the drug coverage for my wife and I pay $7,000 a year. So much for Medicare being a free program. Okay. We don't get our care very well coordinated. You don't have care navigators. Now, if your primary care doc is really excellent, you've got a care navigator potentially. But where are they going to get the time and the staff to be able to do that effectively? We can improve this system. Other things, dental care, mental health services, substance abuse. What we found is that physicians may have somebody that will come into their office, have an abuse problem, they're ready for care. They say, Doc, you know, I want to get this problem corrected. They either don't know how or where to send that person. In this community, with all these resources, your point, health systems, philanthropy, leadership, we still have a lot of people that don't have adequate health care and the system isn't responsible. So my pitch is that we, even in this community, can do a lot better job in our healthcare delivery system. And if we can establish those models, I think they can be replicated in other communities.
Can I just interrupt you and ask Larry, why don't you share just quickly the project that Catholic Social Services has just been awarded a $400,000 grant. And this is a very unique opportunity to describe our 3 other communities that were also awarded and where we fit in comparison.
Sure. Thanks. Our community is just starting an extraordinary venture into a lot of the topics that we've just talked about. We always have to use an acronym. So our acronym this morning is FUSE, which involves frequent users for emergency care. And our project involves an amazing collaboration between U of M and St. Joe's, the Washtenaw Housing Alliance, and a variety of other community providers. And the whole goal is to use data to identify the most frequent users of emergency room services and to provide support services, earlier intervention, and housing to improve their life, but there's obviously the impact. What this really does for us is changes our way of thinking about how problems are created in the first place. We tend to be very linear. We want to think that one thing causes another, and it's simple. And we're able to use a wider systems approach in looking at barriers to mental health care, or substance abuse, or poverty, or homelessness, how these all fester into one another and get in front of the problems before they end up in the emergency. It's very, very amazing. And we're just literally getting this off the ground these next few weeks. I'll say that the health initiative that we're talking about really was critical in our having the legitimacy to even make an application. Our community is one of 4 from around the country that received a federal grant through the Social Innovation Fund. The other recipients were
State of Connecticut.
State of Connecticut. Go ahead, Bob.
San Francisco.
Yeah.
In LA, was it? Yeah, LA. So here
And
we-
Washtenaw County. We've got them surrounded.
Thank you, Larry.
Yeah.
I know Tricia's got a hand up over here for us.
I have a question related to the issue of incentivization and the need for primary care, more primary care providers that you referenced. Is there an initiative to work with educators of the medical schools, the University of Michigan and other medical schools, to set up programs whereby medical students who are willing to provide this kind of care to Medicaid patients could receive over the course of time scholarship money or credits toward repaying their educational loans in exchange for providing this care for X number of years during the course of their career.
I mean, yeah, there are some national loan programs just like that. Long time ago, the National Health Service Corps medical students, if they do go to underserved areas, can get loan forgiveness programs. And so I think it's really not through our initiative, it's much more federally oriented. But I will tell you, the University of Michigan, in their dental program, if any of you have not seen the community dental program, and we're working very closely with them, they are amazing, and they do get students to go, and they get credit for going to practice, and they go around the state to different communities to practice in underserved areas, and have set up community dental programs in many communities in our state. We have a fantastic one here in Washtenaw County that the dental students help staff and help support, and I think it is really a model, and it's never heard the leadership from the U County Dental School talk about this program and how they're trying to really help solve the access program with students.
Could that model be used for the primary care?
We've had that discussion. It's a little bit more complex given all of the requirements for the educational requirements for physicians these days. So it's much harder to change the medical school curriculum. Probably attest to that, but we're having that conversation. So.
Yeah, we've been talking about here, which makes sense because this is the Washtenaw Health Initiative, but looking at the opposite side, okay, the comment was made back here makes me think about my father, who's 94 years old, still lives on his own, still driving, still has a girlfriend, goes out to the club on Tuesday night, all that kind of stuff. And he went to the doctor and was being taken care of by a nurse practitioner. And he was outraged. And he just did not get the idea that having someone other than a physician would be okay. Last week, I think it was, or maybe it was 2 weeks ago, there was a big push in Philadelphia, several other cities. Tom Joyner show was sponsoring a take a loved one to the doctor, and they had this huge clinics where they literally had thousands of people bringing their loved ones to these clinics with the idea that I might not go by myself, but if I trust you and you're my son or my husband or whatever, you might take me. And in talking to someone, I forgot who it was, some nationally recognized doctor, about why certain populations, and particularly Black populations, Latino, Native populations don't come to the doctor, there was a lot of, there's a lot of distrust, that kind of stuff within the community. So I guess my question is, as we're working up here as a coordinating organization to bring healthcare, is part of what you're doing also helping and those communities sort of access also, and is that part of what the ambassadors are? Is that part of what we can social services? Is there a way to
Yes.
help change the mindset of the community?
Yeah, we're not sure exactly how to do it, but for example, there's going to be, with United Way, sponsoring a forum later in the month of November to bring the western side of our county to the table and begin to have that type of conversation. We're also trying to reach out to the churches here in the community and begin dialogue with them so that there's a level of trust that's developed to address the types of issues that I think you're referring to. So we don't know exactly how to do it, but we're in the process of beginning to think through just what needs to be done to reach that segment of our community.
I also think one of the exciting initiatives that's under the Washtenaw Health Initiative is this partnership with Blue Cross that is the largest Medicaid HMO in Washtenaw County. And what they've decided, and it's their actuaries have decided this, which is really fabulous, is that so many people, particularly the low-income individuals who come from medical care, have a really broad range of human service needs. And they can't focus on managing their diabetes if they don't know that they're going to be in stable housing or that they're going to get food. And so in this initiative, Blue Cross is partnering with us to provide social workers to work with the low-income population and really help them sort out what their human service needs are, so that the physicians can really focus on their more medical, clinical needs and not have to deal with all of those other broad-based issues. So I think that's going to be a fantastic pilot, and we'll see if that also has an impact.
I make a comment. One of the aspects of this that I'm very impressed with is the coordination of you folks. I mean, you know, your story, Bob, about how you got very honestly hooked in Norman and Bob. The point I want to make is that there's a few people here with gray hair. I don't, you know, most of us dye our hair because we want that more credibility, right, Bill? Yeah. But I think the point is that there's a lot of, I work with many people who are 60 to, what's your dad now? David, 85?
84. My father?
Yeah.
85.
85. Still running a business.
But I didn't say that.
But that want to really give back to the community. And they want to do, nothing to disparage the Ballet Society or the, you know, the U of M alumni football team or whatever, but I think people want to give back at a meaningful level. And there's tremendous wisdom, knowledge. I heard yesterday a radio program with Jimmy Carter, Nelson Mandela, and Mary Robertson from Ireland, that they've got an elder project where they bring elder leaders together to solve problems around the world. Did you hear that on the radio? But I'm just wondering if you could share some of your insights about how do we get this knowledge out there at plus 60 level. Sorry to discriminate anybody who's under that age, but you know what the sharings you have about that how to leverage that to solve these really big problems that can't be solved within a Blue Cross alone or a U hospital alone, things like that. So, Bob, you didn't want to start it?
Sure. Having been involved in a lot of community projects, you know what? It's really about leadership and trust in terms of how you put these initiatives together. As to how you recruit senior citizens, you know, this community just has tremendous resources of people that are going through changes in their careers, who become available and want to be active to a certain extent. But, you know, to bring people in, you have to have the right idea, you have to have that clear vision and goal about what you're trying to do. You need that support for volunteers. And so, you know, those are just traditional needs that any initiative would require.
Well, I think all you got to do is ask. You know, it was in my career. I was a pretty young guy when I became the CEO at St. Joe's. I was 31 years old, And I relied on people that had a lot of wisdom in this community, Howard Holmes and Harry Towsley and a whole group of people. But one thing we started, I looked for retired executives. And some of you may have been around long enough. You remember Huron Valley National Bank and Jay DeLay? The Apple Bank. Jay, every place he would go, he'd have a bag of apples and give apples out. That was their logo. And so they had mandatory retirement. And so he was president of the bank, he retired. And so I recruited him at St. Joe. I said, Jay, can you come and help us? And he wanted to raise money for the hospital. And it was really interesting. He said, well, I want to help. And I said, well, we'll give you a little office. We converted a closet. And I mean, it literally was a closet. Here's the president of a bank. He was so thrilled. He had great ideas. I'll give you one example. He said, you know, Bob, there are all these retired farmers out around this community. They have this land, they don't know what to do with it. Let's just send a letter to all these farms and see if they'd like to donate the land to St. Joe's. We raised millions of dollars of land that was donated and sold. One retired executive, okay? He worked so hard, he was there every single day. We did that time and time again. And so my answer is, you simply ask. If we make the mistake, it's like my friend here said, I want to travel to baloney, you know, all the initiatives. He has it in his heart, it's in his gut, he knows how to do these things. The same way with Norman, you know, homelessness and housing, etc. Those are the guys that got this done. Well, those talents don't stop when they retire,
Right.
you know? So we simply need to ask. And I think for those of us who have an interest in a social mission, doing good for people, whether we're conservative or liberal, this is an untapped resource in this community. But we
Every
simply,
community, not just this, every community. has
you
it.
got it. Yep.
Steve's got a question.
Seems to me that there's a need for improving the information infrastructure, not just within the healthcare systems internally, but also the community of what's available and making that sustainable in the long run. Because there's coordination between all your volunteers, there's coordination between all the healthcare providers, there's information about what works and what doesn't work in terms of treatment. Can you speak to what the Affordable Health Care Act is going to provide in terms of the information infrastructure?
You want to talk about that in terms of the exchange or the info system and some of the incentives there?
Yeah. So the Affordable Care Act is going to do a lot of things on information, but I really think it is important to understand that it is going to be communities who need to share that level of information. And I think the work that we're doing here will help disseminate, because I don't know that it's got the degree of dissemination that you're really talking about. There are two, I think, major things that are in the Affordable Care Act on the information side. One is the health insurance exchange concept just generally. And, you know, so I don't know how many of you understand what a health insurance exchange is. It's not been very well communicated. And we've had a lot of, as I said, politics in the state. The state wanted to have a state exchange. The governor wanted to have a state exchange. So did the Senate, but the House wasn't ready for that, given the politics around the Affordable Care Act. And so in Michigan, starting in 2014, regardless of what happens with the election, we will have a federal exchange. And what the exchange is really kind of like an Expedia or a Travelocity for buying health insurance. One of the big problems with buying health insurance if you're a small business is you don't know how to compare plans. And so the idea behind a health insurance exchange is to standardize those plans, to have standard benefits. There are called the metal benefits. There's gold, bronze, gold, platinum, silver. Platinum's nice. And then the young invincible coverage for anybody who's 30 or under, but that's not your demographic at the moment, although we have some. And people can buy health insurance that fits these benefit designs. They're standardized. They all have to offer what are called essential health benefits. And the Health Insurance Exchange will help businesses, small businesses, 50 and under, or individuals, compare health insurance plans on price, on coverage, on access. So I think it will help enormously with people's understanding of how to buy health insurance. And the governor said, even if we didn't have the Affordable Care Act, he would want to have an exchange because he knows it improves how the market works for health insurance. So I think that'll be a tremendous advance, whether it's done at the state level or at the federal level. It really will help small businesses.
Yeah, just a follow-up. Because a lot of the healthcare costs are administrative, getting information from providers to insurance companies back and forth, I think the role of the government would be to help establish standards so that cost can be reduced.
Right, so that actually has already happened to some degree. Health plans now are required to provide, of the premiums that they collect, for small businesses, 80% of those premiums have to go for medical care, nonprofits, non-administrative costs, and for larger businesses, 85%. So that is called the medical loss ratio. It's a terrible term. Healthcare has the most amazingly horrible terms to explain things, but it's what it's called. And that's in effect. It's been a big change principally for the for-profit health insurers, mostly outside of Michigan. Michigan, because of the regulations that are on Blue Cross today, already have that kind of a level. So that's already changing, and I think it's a great thing that will go forward in that regard.
I want to make another comment. I have a lot of hope for the future, and on this topic, and the reason is because of the way the culture is changing with younger people. We are making a transition from a paper, if you will, medical record to an electronic record. And so primary care clinics now have electronic medical records. They can send the request for prescriptions electronically to pharmacies, etc. Things are really changing. The problem is how these different systems are going to talk to each other. So we have a long ways to go. But one of the real barriers historically on this has been the privacy concern. Okay? And people my age think, this is my medical. Well, first of all, we have a new understanding that medical record belongs to us. That's my record. That doesn't belong to the hospital, to the doctor. That's my record. I should have access to it. I should be able to get a copy of it. That's relatively recent. So, but the second point is this privacy issue is, I'm afraid somebody's going to look at my record. There might be something in there that will damage me. Well, younger people, think of Facebook and all that. They don't care about that. They're willing to share the records. And I think that may help break down what I think is one of the major barriers for me to be able to communicate, even by email, with my physician. So I have great hope for the future, but it is going to take some real effort to get us there where these different data systems are talking to each other. I have possession of my entire medical record, no matter where I've been seen and by whom. But I think we're going to get there. We're going to have to. That's your point.
Yeah, and I help with the startup community. There's a few startups that are into that right now,
Correct.
Personal health records. But also, covering the pre-existing conditions helps that because you don't have to worry about disclosing that you have something because you're not going to get denied insurance.
Right.
I think that's key.
Remember years ago, some of you are too young to remember this, if you had a heart attack, you didn't tell anybody. Because number one, you'd never get employed. Now it's almost like a badge of honor. I had a heart attack and I've recovered. Same way with cancer.
How many valves got cleaned out?
Yeah, that's right. Let me show you the scar. Now the scar is only that big. It's not from here to here. So things have changed. Hope for the future.
I have a question. You all keep talking about the health insurance exchange. Does it exist?
Does it exist?
Yes.
No, not yet. Well, in Michigan, it does exist in some other states. Massachusetts has one, California has
What's the
one.
plan to,
We've got- yeah.
is that going to be in place?
Yeah, so it will be in place in every state starting in January of 2014. And actually, it's really amazing to think about how soon things are going to happen. Again, this is really, the Affordable Care Act is not going to be repealed regardless of who wins the election. It can't be. And I think these elements are going to continue. So starting in October of a year from now, people will begin enrolling in the exchanges. So it's a very quick time frame. Because Michigan could not come to agreement that we will have a state exchange, the governor wanted to have a nonprofit entity run the exchange. And he could not get through the House, he got it through the Senate. But because we couldn't come to that agreement, in Michigan, it will be run by the federal government, not in the state.
So you brought up another thing. So Blue Cross is supposed to be a nonprofit.
Yes.
And I think that everyone in this room would agree that they are a for-profit company. So how does that exist? How can they be making record profits for as many years as they have across the nation? Each state has their own Blue Cross Blue Shield. They have called themselves a nonprofit for as long as I can remember. So when you talk about communication and distrust and trying to get through the House, a nonprofit, we've already got one, it doesn't work.
That's a very long topic. We can talk about, so I can tell you briefly, and there's of course some legislation now that's also going through the legislature that would convert Blue Cross Blue Shield from what it is today to be a nonprofit mutual insurance company, which would be regulated in a different way, but still a nonprofit. Blue Cross is regulated today under Public Act 350. It is a nonprofit corporation, so it does not distribute money to shareholders. It doesn't have shareholders. There are Blue Cross plans in the country that are for-profit, particularly in California. They are for-profit. They have shareholders. They operate very differently. What the law does for Blue Cross in Michigan, what is really unique about Michigan, is that Blue Cross has always been the insurer of last resort. So if you are sick, you cannot be excluded by coverage by Blue Cross. That is not true almost anywhere else in the country. And people who are sick with what are called pre-existing conditions, many of them cannot get health insurance with them. And that's going to be fixed by the Affordable Care Act. All health plans will have to take everybody, regardless of their health status. In Michigan, that has been true really only because of Blue Cross and Blue Shield. Now, I think what you're reacting to is where they set premiums and whether they put a lot of those premiums, whether they have very high levels of reserves. Theoretically, those reserves are owned by the state of Michigan. And one of the interesting discussions in this conversion to a mutual insurance company is what is proposed is that Blue Cross will contribute $1.5 billion to a new nonprofit health and wellness fund that will distribute $100 million per year to the state to improve health, probably, I'm guessing, to keep premiums for seniors, for Medicare complementary lower than they would be otherwise. So that's money that's going to come back to the state that will have an independent board that's not connected any longer to Blue Cross, but Blue Cross will be funding it. So those reserves that they have are going to go to the state, benefit of the people, however that board decides that will be carried out.
So, yeah, and thank you, that's helpful. But to me, the tough question is, why isn't Blue Cross making the health insurance exchange happen today? If they've got that kind of money in reserve, why can't we make it happen today? So that's the question to take back to your board. Blue Cross Blue Shield, get off the fence and make it happen now. Be the leader.
I know it's 9, and how are you guys for time? Because I think if people have to leave.
How about a couple more questions?
How about, okay, so let's see, Pat, who's had their hand up? Steve, Ellen, okay, 2 more. Steve always has his hand
I
up.
always have my hand up, yeah, so just don't pay attention to that. Question about So primary care and prevention, the right thing to do. Do we have local demonstration projects or research that shows that it actually reduces the cost of health care? Especially locally, if you're aware of any demonstrations of that.
That shows that primary care lowers the cost of health care.
Primary care and prevention services.
Prevention services. Yeah.
To low-income population.
So what we have actually, what we have is data that shows that when the low-income population gets coverage for Medicaid, and we have a wonderful study actually that just came out from Oregon, they improve their health and they get care in a more integrated, better way. Do we know that it saves money? No. But we do know that they get much more efficient and better care, and that they do move their care from the emergency department, which is a terrible place to get ongoing care. The reason that I think it's very difficult to show that it saves money is because a vast number of this population have unmet health needs. And so even though they're getting care in the emergency department now, but they're only getting care when they're in crisis. And so if you're diabetic and you need ongoing medication, you need ongoing doctor visits, what actually happens when people get health insurance is they have unmet health needs and they increase their use of health care. It's just better health. And so it's better for them and their families, it's better for their lives. We have a lot of data on that. We don't have data that shows it saves money. And that's true generally for prevention. Preventive services, every politician likes to say we're going to save money in healthcare by prevention, by getting rid of waste and abuse and things like that, and we really don't have data to show it saves money. Prevention generally increases the cost, but it's healthcare in total, but it's very cost effective. It's a good thing to do. It's the right thing to do. It doesn't save money in healthcare, except for things like immunizations, those kinds of things. Generally, preventive services don't save money because people get more care. So,
Ellen, you get the last question.
Okay, so my question is to take it back to something that Marianne, you said earlier in your remarks, and you mentioned evidence-based outcomes. Are there any demonstration projects that are looking at that as an incentive versus fee-for-service?
Oh, yes. Huge, and that is a very significant part of the Affordable Care Act is to change how providers are paid so that to both get them to use more evidence-based care and to move away from fee-for-service. And I'll just give you two very quick examples. Michigan was chosen as one of 8 states to run a demonstration project on what's called, and this is just a horrible name, patient-centered medical home. And whenever I say that to consumer groups, they say, oh, you're going to put everybody in skilled nursing facilities. That is not what it's about. It is actually about making sure that patients have connections to primary care practitioners who work as a team to really coordinate their care in a very different way than they have historically, and to make after-hours care available so they don't go to the emergency department and so they don't get repeat tests and things like that. We're getting about $35 million a year more in Medicare payments in our state. It's mostly going to primary care physicians to do that coordinated care. And it's a 3-year demonstration, started in January this year. Actually, our center is administering that in partnership with the state, in partnership with the University of Michigan. And we will have, I think, after that, some good data to say whether getting people coordinated primary care does save money and does improve the quality and the outcome. And physicians are compensated differently under that demonstration project to try to move them away from the current structure. The second one that's very exciting and that our community is doing some really interesting things on are what are called accountable care organizations. And the idea there is to partner physicians and the hospitals together to, again, coordinate care differently across the continuum. The University of Michigan was a demonstration project. The health system here was a demonstration project for the precursor to this program and demonstrated that it could save money. It was actually one of only 2 health integrated systems in the country that for all 5 years of the demonstration project showed it saved money. And where it saved money was primarily as patients, these are Medicare patients, as they got discharged, in doing a better job in making sure when they got discharged their care was coordinated, they got back connected to primary care, they were doing the follow-up care so they didn't end up back in the hospital again. And that program has also a different compensation mechanism where providers have incentives to do a better job on coordinating care. It's a very exciting demonstration. The University of Michigan really showed how you can make a difference, particularly with people who are very sick. That is really where the money is in healthcare. It's where the savings opportunities are in healthcare. People have a lot of chronic disease, a lot of problems, where you can do a better job of coordinating their care.
I want to just thank the panel for we appreciate your knowledge and your wisdom, and I think that we're all living in a very exciting time when we're beginning to come to a point where we can deal with some of these issues, and it's a huge, huge problem. Next month, actually 2 weeks from today, is our next program, and it will be a great follow-up because it's Ken Dalfor, who is the Senior VP of Blue Cross, and he's responsible for many of the programs at Blue Cross. He's going to be actually talking about leadership in the healthcare system, and he's a former Detroit Lion, and he's going to be talking also about coaching as leadership. So that's his theme. So see you in 2 weeks, and please feel free to hang out if you want. Some food to bring back to your employees, to families, whatever, to share. We don't want to leave anything behind. So thank you very much again, and we'll see you in 2 weeks.
Thanks.